Today's speaker is Kristen Fullman. Kristen is a PhD candidate at the University of Buffalo in the Pharmaceutical Sciences Department. Here she studies the impact of transporters on special populations and in drug overdose. Kristen earned her bachelor's degree in biochemistry from Canisius College.
Well, thank you for that introduction, and thank you, Sutara, for having me, and thank you for everybody calling in. Good morning. I'll get started today with the talk, and you all know the presentation is about leveraging in vitro data to improve prediction of drug clearance in renally impaired populations. I have a brief outline going through what I'll be talking about today. So first I'll go through a little bit of background through the hypothesis-specific aims, and then I'll be going through my methods and results for aim 1 and aim 2 separately, and we'll end with conclusions and future directions and get into that Q&A session. I'd like to point out that the work I'm presenting today is from one of my more recent publications in drug metabolism and disposition. So if you're interested in the work and you want to see it in more detail, you can look at this publication. So renal impairment is the disease state of interest for this project. So what is renal impairment? RI is the gradual and permanent loss of kidney function. The current prevalence of RI in the United States is around 13%, and it has a projected prevalence of around 17% by 2030. RI presents alone and with other diseases, and it's long been known that RI impacts the pharmacokinetics of many compounds. So we're really interested in how renal impairment does this so we can better predict it in this population. So glomerular filtration rate, or GFR, is one of the major ways that renal impairment is categorized. So GFR is defined as the total amount of filtrate produced per minute by glomeruli of all nephrons in both kidneys of an individual. This can be estimated a couple of ways. The most popular way is through creatinine clearance. Creatinine is an endogenous compound that's filtered in the kidneys, and so it's a good measure of GFR. It does have a secretion component to its renal clearance, so it tends to overestimate GFR a little bit, but because it's endogenous and it doesn't need to be administered, it's the most popular way to estimate GFR. Inulin is kind of the gold standard of GFR estimation, but this compound needs to be administered, and so it's not used as often. The table on this slide goes through the description of the different categories of renal impairment, from normal renal function all the way to ESRD, or end-stage renal disease, and the estimated creatinine clearance, or estimated GFR, that accompanies that category. So when you have a GFR over 80 milliliters per minute, that's considered normal renal function, and as that drops down, we have more severe degrees of renal impairment, and we have severe renal impairment, which is less than 30 milliliters per minute of GFR. Now, in this population, in renal impairment, there are some dosing adjustments that are necessary for certain compounds. This table is from a 2007 publication. It looked at many different types of compounds. Here, I'm just showing an excerpt of diuretics. And this table has different dose adjustments that may be required. So if we just look at the first drug in this table, amelioride, the usual daily dosage of this compound is 5 milligrams. And for individuals with an estimated GFR over 50 milliliters per minute, the normal dosage is fine. However, when the GFR falls below 50 milliliters per minute, there is a dosing adjustment that's necessary. The dose should be reduced to 50% of its usual dosage. And finally, if we have people with GFRs less than 10 milliliters per minute, you want to avoid the drug completely. So these are pretty drastic changes to the dosing that's required in different subsets of renal impairment. And so it's really important that we can inform this dosing adjustment properly as we move through drug development. And the reason why we have these dosing adjustment requirements are because of the changes and the impact of renal impairment on the pharmacokinetics of certain compounds. So this table here, it's a 2008 table from a 2008 publication that looks at changes in clinical pharmacokinetics for different compounds. I've highlighted cyclophosphamide here right in the middle of the table, and what we're looking at is PK parameters in a normal population and a CKD, or chronic kidney disease population. If you look it's right around the center at total clearance, you can see that in a normal population, the total clearance of cyclophosphamide is around 80 milliliters per minute, but in the CKD population, total clearance is only 47 milliliters per minute. And what contributes to this change in total clearance is a change in renal clearance. And we see that for normal compared to CKD patients, there's a pretty drastic reduction here in renal clearance. And you might expect this due to the decrease in GFR, which contributes to renal clearance. But there's also changes in non-renal clearance. And the non-renal clearance decreases from about 64 milliliters per minute to about 45 milliliters per minute. So there are a number of pathways of elimination that can be affected in renal impairment, and changes in PK in renal impairment are not restricted to just changes in GFR. So I want to talk a little bit about these other factors in renal impairment that can impact PK that require further investigation. So one of these factors is the expression of drug metabolizing enzymes. So this figure is adapted from a 2011 publication that looked at the hepatic CYP expression in renally impaired populations. And now the CYPs, or the cytochrome P450s, are a major family of drug metabolizing enzymes in the body. So this table looks at percent of original expression for a variety of CYPs that are listed on the x-axis of the figure for moderate and severe renal impaired populations. The moderate renally impaired population are represented in the blue bars, and they have GFRs ranging from around 30 to 59 milliliters per minute. And the gray bars are the severely renally impaired population with a GFR of less than 30. And what you can see is that for these various CYPs, there is a reduction from the original expression of these hepatic CYPs. And so what this tells us is that there is potential for impact of enzyme clearance of compounds in renal impairment based on changes in expression of drug metabolizing enzymes. There's also a lot of evidence for impact of renal impairment on drug transporters in renal impairment. So we can look at the figure on the left, which looks at ASP uptake. ASP is a substrate of OCT2, or organic cation transporter 2, which is a major renal transporter. And the x-axis of this figure has acrolein concentration. Acrolein is a compound that's endogenous to the body, and it can accumulate in renal impairment. It's known as a renal toxin, or uremic toxin. And this experiment was performed in an immortalized human proximal tubular epithelial cell line, and you can see that as the concentration of this compound, acrolein, increases, there's a decrease in ASP uptake, which indicates a decrease in the activity of OCT2. Similarly, this has been demonstrated quite frequently in preclinical species. So the table on the right goes through many different transporters in the kidney, liver, and intestine, and shows that there are evidence of both quantity changes and activity changes for drug transporter in renal failure. So we can see a change in drug metabolizing enzyme activity and expression. We can see a change in drug transporter activity and expression. And there's another factor that I want to talk about, which is fraction unbound. So fraction unbound has also been demonstrated to change in renal impairment, and this can be due to a number of factors. You can have hypoalbuminemia, you can have qualitative changes in protein binding site, and you can also have competition for binding, and this can be mediated through increased concentrations of uremic toxins, concentrations of the drug itself due to decreased clearance of the compounds. And this table here is from the 1984 publication that looked at protein binding of different compounds in a normal population and in an end-stage renal disease population. And I've highlighted naproxen because it has a high change of protein binding in the two populations. So for normal patients, there's about a 75% protein binding of naproxen, but in end-stage renal disease, the compound is only 21% protein bound. So this is a huge increase in fraction unbound that could have a profound impact on the pharmacokinetics of this compound. I want to talk a little bit more about renal clearance and the components that contribute to renal clearance because renal clearance is the major endpoint of interest for the talk today. So renal clearance is defined as the volume of plasma cleared of a drug per unit time by the kidney. More specifically today, we'll be talking about amount of drug excreted unchanged into the urine. And at the top right of the slide, you can see this equation for renal clearance. So renal clearance is equal to fraction unbound times GFR, which represents the filtered fraction of the drug, plus renal secretory clearance times 1 minus the fraction reabsorbed. So renal secretory clearance and fraction reabsorbed, these can be passive or facilitated processes. So if they're passive, they can just be mediated by the physiochemical properties of the compounds and the conditions that are present in the blood and in the urine, and they can also be facilitated by transporters. You can get an idea of what process is dominating in renal clearance if we just look at the value for renal clearance. So if renal clearance is approximately equal to the filtered fraction, it's likely that you don't have any net reabsorption or secretion occurring. If renal clearance is much greater than the filtered fraction, you have net secretion, and if renal clearance is much less than the filtered fraction, then you have net reabsorption. For this project, we wanted to subcategorize compounds based on what process is dominating in the kidney in order to kind of zero in on the changes in renal impairment that are affecting certain processes for certain compounds in the kidney. So for the talk today, we'll be talking about net secreted compounds, so compounds in the middle category here. I also want to talk a little bit about our approach. So we decided to use a simulation-based approach for this project for a number of reasons. The first is that simulations allow us to investigate the impact of certain determinants on endpoints such as renal clearance. We wanted to be able to utilize information from a wide range of sources. We wanted to use clinical, preclinical, and in vitro data, and we wanted to probe the impact of renal impairment on model substrates in order to create a greater understanding of the impact of RI on certain elimination pathways. So the hypothesis that we have for this project is a simulation-based approach utilizing physiologically based pharmacokinetic models can provide insights on how pharmacokinetics are altered in renal impairment. And we approach this hypothesis with two aims. The first is to evaluate the effect of specific determinants on pharmacokinetics of compounds undergoing active secretion in the kidney. And these determinants that we'll talk about are changes in GFR, fraction unbound, drug transporter, drug metabolizing enzyme expression, and toxin-drug interactions, which would be inhibition of transport mediated by accumulated concentrations of uremic toxins. And finally, the second aim is to evaluate the utility of preclinical and in vitro data to improve the prediction of pharmacokinetics in renal impairment. So we'll start by going through the methods and results for aim 1. Now, in order to facilitate aim 1, we needed to choose a model substrate, and we got to metformin through a process. We wanted to use Simcyp for this project. Simcyp is desirable for a number of reasons, but it really lends itself to this project. Simcyp has a number of built-in compound files, so these are models that have been created and validated and are available for use for situations such as these in Simcyp. Simcyp also has different populations, so they have a healthy volunteers population, and they have two different renally impaired populations, a moderate and a severe impaired population. So based on these properties, and Simcyp also being that it's a PBPK platform, it gives us access to change and manipulate all these different factors. So it really was ideal for this project. And so what we did was we went through the built-in compound files that are available in Simcyp, and we chose metformin because it is actively secreted in the kidney, and it's highly eliminated in the urine, and it's a really ideal substrate for this project. Metformin is a biguanide anti-hyperglycemic agent used for the treatment of type 2 diabetes, and it's contraindicated in RI patients. So a little bit about metformin PK. Like I said, it's highly excreted unchanged in the urine, over 80% of the compound. There is a slight contribution of metabolism that's likely mediated by CYP3A4. It has a decent bioavailability of around 55%, and again, metformin renal clearance is much greater than GFR. This is the pathway for metformin renal secretion and the transporters that are involved in this secretion. So the first is organic cation transporter 2, or OCT2, which I've mentioned. So OCT2 is an uptake transporter located at the basolateral membrane of the renal epithelial cell. OCT2 mediates the uptake of metformin from the blood to the renal epithelial cell. Metformin is then excreted into the urine via two transporters, MATE1 and MATE2K, or multi-drug and toxin extrusion proteins 1 and 2K. So this is the pathway that metformin takes, and this is what's described in the metformin model in Simcyp that we utilized for this project. So I want to talk a little bit more about this model. So the next couple slides have figures and tables from a 2016 publication that also utilized this Metformin Simcyp model. This slide has a high-level overview of the model that is used in Simcyp, and it tells us which modules are called in Simcyp. So the center panel here indicates that the full PBPK model was used in Simcyp as opposed to a minimal PBPK model. And then on the left and the right, we have the modules for the liver and the kidney, and for both of these organs, we're using the more mechanistic component in Simcyp. So we have the permeability-limited liver model and the mechanistic kidney model. Both of these modules allow us to incorporate transport across the epithelial membranes, and importantly, the mechanistic kidney model has different compartments for the different segments of the nephron, and has transport at the different segments. So it's a highly detailed model, which was ideal for this project. So moving on to the parameters for the model, the first set of parameters is for the physiochemical and blood binding properties of metformin. You'll notice that fraction unbound for metformin is 1, so this compound is not bound. The absorption for metformin was handled by simple first order absorption Ka. There was a T lag, and of course fraction absorbed is incorporated. Distribution in the model again was handled by a full PBPK. If we move on to the transport parameters, we have transport in the kidney listed first. So here are OCT2 and MATE1 and 2K. Transport by MATE1 and MATE2K is handled together in Simcyp. And you'll see that the transport is defined here by an intrinsic clearance and also an RAF. RAF is a relative activity factor, which helps scale. It's a fitted parameter, and it usually helps scale from in vitro to in vivo in Simcyp. And there's also a passive diffusion clearance in the kidney for metformin. Similarly, in the liver, there's another transporter involved in this model, so it's OCT1, or organic cation transporter 1. This is a transporter which mediates the uptake of metformin from the blood to the hepatocyte. Again, there's an RAF for this transporter, and there's a passive diffusion clearance in the liver as well. And I do want to point out that the metabolism of metformin in this model is handled by an intrinsic clearance parameter in the human liver microsomes. It's not assigned to specific enzymes. So for that reason, and because metformin is not highly metabolized, we didn't look into changes in drug metabolizing enzyme expression and activity in this aim for this compound. So we'll be looking mainly at impact of the expression and activity of transporters and the impact of fraction unbound. So I wanted to show the performance of the model just to give us confidence in how well this model is performing and why it's useful for this project. So this, again, is from that 2016 publication that looked at the performance of the simulation of Metformin PK in reference to its observed values. So the symbols in each of these panels, the circles, the crosses, and the open triangles, these are all observed data. And then the gray lines and the black lines are simulated trials for metformin. So you can see that in single dose in panel A, multi-dose in panel B, urinary excretion in panel C, and predicted mean AUC in panel D. The model is performing quite well and is able to capture the observed data. So we were confident moving forward. So this brings me to our results for this aim. So on these slides, we'll be looking at tables with renal clearance values and fold changes in renal clearance, and we also have a 3D figure that has the same information in graphical format. So you'll notice the columns in this table are labeled GFR percent. Again, in Simcyp, there are 3 populations that we use, which were the healthy volunteers, which represent a GFR of 100%, moderate renal impairment, which we gave a GFR of 50%, and severe renal impairment, which we gave a GFR percent of 10. And this was so that we could translate those GFR ranges into point values in order to put it in the 3D figure. So if we look at this first slide of results, we have renal clearance for the different populations and different doses of metformin. And you can see that for each dose, there's a significant decrease in renal clearance as we go from a healthy population to a severe renally impaired population. And it's about a 1.8-fold reduction in renal clearance with severe renal impairment, and this wasn't really affected by dose. I do want to point out that the results that I'm going through today for AIM-1 are in completely male populations. I did perform the simulations in parallel for completely female populations. The absolute values for those for renal clearance was reduced in that population, but the trends were the same. So for the sake of discussion, I'm not going through them, but they are available in the supplemental information of my publication if you're interested. So we can move on to the impact of drug transporter expression. So again, we have the three populations in the three different columns. For original drug transporter expression, I have the actual value of renal clearance, and then for plus and minus twofold of drug transporter expression, I have fold increase and fold decrease in renal clearance. And this is in reference to the renal clearance for the original drug transporter expression. As expected, we can see that with an increase in drug transporter expression, there's an increase in renal clearance. And this is because the capacity of the system to excrete metformin into the urine is increased. Similarly, with a decrease in drug transporter expression, we see a decrease in renal clearance, again, because the capacity of the system to excrete metformin has been reduced. Interestingly, we see that this effect is magnified in renal impairment. So for an increase in drug transporter expression of 5-fold in a healthy population, we see a 1.6-fold increase in renal clearance. This is increased to 2.2-fold when we're looking at the severe renally impaired population, or the GFR of 10%. And this is likely due to the fact that as we're reducing our GFR so much, the reliance of renal clearance on transport is increased, and so any change in that transport results in a greater change in the renal clearance. The next thing we looked at was the impact of toxin-drug interactions, and to do this, we used the parameter R. R is the ratio of a concentration of an inhibitor to its Ki, so it's the concentration to the potency of the inhibitor. I have the transport of metformin here just for reference, and we looked at two different types of inhibition. We looked at competitive and non-competitive inhibition. So R modifies Michaelis-Menten kinetics differently for different types of inhibition. For competitive inhibition, R modifies Km, and it results in an increase in Km. So this is a decrease in the apparent affinity of the transporter for its substrate. In non-competitive inhibition, R modifies Jmax, which is just Vmax for transporters, and R decreases Jmax, so it decreases the apparent capacity of the transporter for its substrate. So as R increases, the degree of inhibition increases. And for this project, we looked at R's ranging from 0 to 100. So again, in this table, we have the healthy, moderate, and severe RI populations in the columns. In the rows, we have R from 0 to 100, 0 being no inhibition, 100 being a very, very high degree of inhibition. And if we start by looking at the healthy population, we see that there's a 4-fold decrease in renal clearance as R is increased from 0 to 100 because we're preventing the secretion via transporters into the urine, so we're decreasing renal clearance. This impact on renal clearance is increased to about 9-fold when we go from healthy population to a severely renally impaired population, and R is increased from 0 to 100. So similar to the drug transporter expression, we're seeing an increase in the impact of drug transporter activity in renal impairment as well. So these are the results for non-competitive inhibition for OCT2. Competitive inhibition yielded very similar results. Again, that's in the supplemental information for the paper. The final factor was the impact of fraction unbound, and we can see that as we increase renal clearance, if we increase fraction unbound from 0.1 to 1, there's an increase in renal clearance. And again, this is somewhat dependent on the function of the kidneys. So as we see for healthy or moderate renally impaired individuals, there's over a 5-fold increase in renal clearance with an increase in fraction unbound, and this is slightly reduced in the severe RI population. So to conclude for A1, decreasing GFR results in decreased renal clearance. There's a direct relationship between drug transporter expression and renal clearance for an actively secreted compound. Inhibition of drug transporters results in a decreased renal clearance, and this was not dependent on the type of inhibition. And finally, an increase in fraction unbound results in an increase in renal clearance. and I've highlighted the two effects that seem to be magnified by renal impairment. So we'll move on to aim 2. So aim 2 was to evaluate the utility of preclinical and in vitro data to improve the prediction of pharmacokinetics in renal impairment. So as we move into aim 2, we wanted to add another model substrate, and we selected this compound through a similar process as metformin. The compound that we added was ranitidine, and we wanted to include this because it was available to us and because it had a similar renal secretion pathway to metformin. So we wanted to see if we were able to improve the predictions of metformin PK. Is that specific to metformin, or is it applicable to another substrate of OCT2 and MATE1-2K? So ranitidine is an H2 receptor antagonist used for the treatment of gastrointestinal ulcers. It is also highly excreted in the urine. It has a fraction excreted of about 66%, and dose adjustment is recommended with creatinine clearance less than 50 milliliters per minute. So here is the active secretion pathway for ranitidine, and again, you'll see the same transporters involved as metformin, but we're just adding one more here, OAT3, or organic anion transporter 3, which is also present at the basolateral membrane of the renal epithelial cell and mediates the uptake of ranitidine from the blood to the renal epithelial cell. So here are the ranitidine model parameters, and I do want to point out that the ranitidine model came from a 2013 poster presentation from Dr. Neuhoff from Certara, and the compound file was graciously provided to us for use in this project as it's not built into Simcyp just yet. So here are the ranitidine model parameters. Again, we'll start off with the physiochemical and blood binding. The fraction unbound is still quite high, 0.96. The model utilized the full PBK distribution model, and again, we have transport listed similar to the metformin model where we have OCT2. Instead of having an intrinsic clearance here, we have Jmax and Km, which is just another way to parameterize transport in Simcyp. We have OAT3 transport here, and MATE1 and MATE2K is still indicated with an intrinsic clearance. We also have transport in the liver, and this is another uptake transporter. It's OATP1B3, organic anion transporting polypeptide 1B3. Again, it mediates the uptake of ranitidine from the blood to the hepatocyte. And again, metabolism in this model is mediated by an intrinsic clearance. It's not assigned to a specific enzyme. Just a quick slide on the performance of the model. So the open circles are the observed data, and the gray and black lines are the simulated trials, and the dashed lines are the percentiles. This is the 95th percentiles. Again, this comes from that 2013 poster publication, and you can see that for different doses of a single dose as well as a multi-dose data that the model performs quite well. The other thing we needed for this aim was clinical data to compare our simulations to. So for metformin, the data came from a 1995 publication that had PK in a moderate and a severe chronic renal impairment population. This was an 850 milligram oral dose of metformin. The samples were collected for 72 hours, so simulations were performed to 72 hours, and these simulations included 5 trials with 5 subjects in each, and we matched demographics of the simulations to the demographics for the clinical data. Similarly, with ranitidine, the information came from a 1997 publication. This was an intravenous dose of ranitidine of 50 milligrams. Again, samples were collected for 72 hours, and I performed 5 trials with 5 subjects in each for each condition, which I will get into next. I do want to point out that for this publication, they had separated their populations into 5 groups for renal impairment as opposed to 3 that I've been using, which is healthy, moderate, and severe. And so I combined groups 2 and 3 to be the moderate RI population and groups 4 and 5 to be the severe RI population for purposes of comparison. And that was done based on their estimated renal function. So in order to understand how we can potentially improve the predictions of renal impairment in PK, I needed to see what data I could use to alter these factors that we looked at in AIM-1. So is there data supporting alterations of expression of OCT2 or activity of OCT2? So that's what I looked for next. And this is literature data, so I was really open to any source of literature data, whether it be, you know, preclinical or preclinical species or clinical species, and what I was able to find for expression was preclinical. And so I have data in rat and in mouse that I found, and the publications are listed here. And so what I was looking for was changes in expression. And so the top figure here on the right, the bar graph, is percent of control of protein expression of these different transporters in chronic renal failure rat kidney. And so this is changes in expression for these different transporters in rat. And what you'll see is that for a number of the transporters that we've been talking about, OAT3, OCT1, OCT2, there is a decrease, a significant decrease in their expression. And so I took an approximation of this quantitative change and used it in my simulations, which I'll talk about in a moment. And then for MATE1, I found an mRNA data in a transgenic mouse model for renal failure and saw that there was no change in mRNA. And although mRNA doesn't always correlate to protein, this was what I could find, and so I did not incorporate any changes in MATE1 for my simulations. I did not find any information on OATP1B3, so changes in expression for this transporter were not included in my simulations. The other thing I wanted to look at was toxin-drug interactions, or TDIs. And so what I did here was I looked for instances in the literature where specific uremic toxins were shown to inhibit the transporters of interest. And then I looked for a potency term, so Ki or an IC50 for that inhibition. And then I also looked for documented concentrations of that specific inhibitor in renally impaired populations. And then I used this information to obtain an R value, which is just the concentration in the RI population over the potency term. I took an average where I had multiple instances, and then the final column has the R I utilized in my simulations. So to kind of combine the last two slides and explain a little bit more clearly what I did, so I was kind of collecting conditions, different modifications to transporter expression and activity that I had evidence for in the literature to include in my simulations. And I used those values to alter the expression and activity of the transporters in Simcyp and perform new simulations, and then take the results of those simulations and compare them to the base simulation as well as to the clinical data and see, are we seeing an improvement in the prediction over the base simulation or not. And so for metformin, I have the conditions all listed here, as well as for ranitidine for the different transporters of interest. And I didn't include drug metabolizing enzyme changes. As I said before, we haven't assigned the metabolism for these compounds to specific enzymes, and I didn't change for Action Unbound because both of these compounds do not experience significant protein binding. So we're really focusing in on the transporters here. And what I did was I performed every possible combination of these factors. So each combination alone, and then 2 at a time, 3 at a time, et cetera, until I performed every combination of these factors, and then I compared the results of the simulation to the base simulation as well as to the clinical data. And what I'm going to show you today is for both moderate and severe RI for both compounds, the most improved simulation. So I'll start with metformin for a moderate RI population. Again, I just want to remind that this is oral administration. These slides are all set up the same. The left panel has the base simulation. So this is just the metformin file in Simcyp with the moderate RI population in Simcyp with no modification, and the right panel has the modified, the most improved modified simulation with the modification listed under the title. So the modification in this instance was 20% of OCT2 expression. The black dots are the observed data, and the lines represent the simulated mean, 5th, and 95th percentile of the trials. The tables below have the different PK parameters. We have the value of the observed parameter. The base SIM-GFR 30 to 60 is the base simulation in Simcyp, and OCT2 20% is the modified simulation. And finally, we have in bold and italicized the predicted over observed ratios, which is what we can look at for the most easy way to compare these simulations. So you can see that for when we compare the predicted over observed for the modified to the base simulation, there's an improvement in prediction of all PK parameters. Most specifically, if we look at renal clearance, the predicted over-observed for the base simulation is around 3, which is quite a high over-prediction. But this is corrected in the modified simulation, and we get a predicted over-observed of 1.19. And the improvement is highlighted here in green. When we move to a severe RI population, we see, again, an improvement in most of the parameters. Again, renal clearance is over-predicted in the base population and more well-predicted, more accurately predicted in the modified simulation. And the modification for this population that led to the most improvement was inhibiting OCT2 with an R of 2. And we can see here, for the amount excreted, the base simulation had a more accurate prediction of the amount excreted, but even in the modified simulation, we're still within 2-fold, which is a general bar that we want to be within for our PK parameter predictions. Moving on to ranitidine in a moderate RI population, you can see just by looking at the figures that both simulations performed quite well. The base simulation is capturing the majority of the observed data, and you can also see the predicted over-observed ratios are quite good for the base simulation. There is a slight improvement with the modified simulation, and here the most improved modified simulation include a reduction in the expression and activity of OCT2. But both simulations performed quite well. However, when we move to severe renal impairment for ranitidine, you can see that the base simulation is really under-predicting the observed concentrations for ranitidine. But with our modified simulation, we see that we are actually capturing the data. There was quite a few modifications for this most improved simulation. There was a reduction in the expression and activity for OCT3 and OCT2. But you can see the most drastic improvement was in the renal clearance parameters. So for renal clearance, it was almost 5-fold over-predicted, but it was well-predicted in the modified simulation. Amount excreted was, again, over 3-fold over-predicted and well-predicted in the modified simulation. So there was an improvement. So to conclude for AIM-2, inclusion of expression and activity changes for OCT2 and OCT3 improved pharmacokinetic predictions for metformin and ranitidine. To conclude, overall, GFR, protein binding, drug transporter expression, and toxin-drug interactions are important determinants of PK in renal impairment. Incorporation of expression and activity changes for relevant drug transporters based on preclinical and in vitro data improves PK predictions for metformin and ranitidine. And finally, a simulation-based approach was useful in investigating the impact of determinants in RI and improvements of predictions for clinical PK. For future directions for this project, we want to investigate more specific elimination pathways, so more drug transporters and drug transporters pairs like OCT2 and MATE. Also want to look more closely at drug metabolizing enzymes, and the overall goal would be to determine the best modifications for specific pathways to help inform a priori predictions of PK in RI. So to kind of flesh that out a little bit more, for the AIM-2 results, I went through the most improved prediction for each subcategory, so each compound and each RI population, be it moderate or severe. Well, ideally what we'd like to do is kind of draw some sort of overall conclusion for multiple model substrates of the same pathway, elimination pathway, and see maybe not what conditions lead to the most improvement for a specific set of conditions, but which modifications lead to an improvement across the board. So here I have 2 tables that look at the base simulation, decrease in OCT2 expression and a decrease in OCT2 activity, and then the parameter AUC, area under the curve or exposure of a compound, renal clearance, or amount excreted. And when there's an improvement with the modification over the base simulation, I've highlighted that in green. And you can see that for both a decrease in expression or activity of OCT2 for metformin and ranitidine, we've seen improvement in most of these parameters. So if we were able to expand this to more model substrates and just expand the analysis in general, we might be able to make some conclusion that for a moderate RI population with an OCT2 substrate, you'll have a better prediction if you reduce its expression to 20%. So that's the overall goal. And with that, I'd like to just make a few acknowledgements. My advisor, Dr. Morris, in the Department of Pharmacy and Pharmaceutical Sciences. I'd also like to acknowledge Bristol Myers Squibb, or BMS. This work was part of a fellowship which was granted by BMS, and Drs. Ming Zhang and Tarek Leal were really helpful in developing this project and editing my manuscript, so I'm really appreciative toward BMS. And with that, we can take any questions.
Great, thank you so much, Kristen. Looks like we have a ton of questions for Kristen in our Q&A box, and we encourage folks to continue submitting their questions to Kristen in the Q&A box in your lower right of your screen. And we also have my colleague from Simcyp, Miley D'Souza Mendez, on the line who may chime in. So Kristen, first question from our audience. For ranitidine hepatic uptake, the focus was on OCT1B3. Ranitidine, however, has been shown to be an OCT1 substrate. Was the contribution of OCT1 mediated uptake not investigated, or if it was it found not to be as contributory as OATP1B3 for ranitidine?
Yeah, so that's a great question. In my analysis, OCT1 for ranitidine was not included, not in hepatic uptake or any sort of contribution that it might have had in the kidney as well, as it's expressed there as well. That's one of the major limitations of the study, is that we are using models that have been developed. So what you're highlighting is that there's a potential for improvement of the ranitidine model, and that's true. That might more accurately characterize the hepatic uptake of ranitidine. It's not just OATP1B3, OCT1 is also influential. But because the model didn't already include that, it's not investigated in the analysis. So while we want to include more model substrates to kind of get at this question more, we also might want to think about making improvements to the model, such as inclusion of more transporters, which have been highlighted to be important by other studies. So no, we didn't look at OCT1, and yes, it might be important. It might be something we need to look at, but we're kind of just doing what we can with the models that we already have, instead of trying to improve the models further.
Someone asks, I would assume that not only the GFR but also the kidney blood flow is quite important to predict the renal clearance. How was this included in the modeling process? Was it assumed that the kidney blood flow is comparable between healthy volunteers and renally impaired patients? If so, is there literature that supports this assumption?
So blood flow was not altered in the simulation beyond what is in Simcyp. So all of the changes that I made to the renally impaired populations I talked about, and no other physiological parameters were altered in Simcyp. And I think that Simcyp has kind of the most extensive tool available for the physiological changes in renal impairment, but our understanding of renal impairment is still progressing. Something like urine pH is important in this, but since there's not really a consensus yet, we're not really incorporating it quite yet to how we could change these different parameters in order to make a more accurate physiological representation of renal impairment. So no, I didn't include any of those changes, but they might be important, yes.
One of our attendees thanks you for sharing your work and asks, do you think the base model for metformin can be used to evaluate the drug-drug interaction effect of inhibitor drugs on MATE2K on metformin?
That's a good question, and I would say that it would depend. It would depend on what inhibitor you're looking at. So if you because MATE1 and MATE2K are handled together in Simcyp, there's no separation of the transporters. So the parameters that define MATE transport are one and the same. And so if you had data that could separate them, I mean, maybe Maylis could speak more accurately to this.
Yeah, I can try to help. So the actual model for the DDI is not exactly the best One of my colleagues, Howard, have developed the EGD model, which has actually the interest is because they've seen that when you inhibit MAGE, actually you will have an increase of the concentration inside the cell. And because of this increase of concentration inside the cell, then the potential of the membrane for OCT2 will change, and OCT2 transporter at this point will not act as an uptake transporter, but more as an efflux transporter. So if you want to look at DDI with MAGE, if you don't take into account the really particularity of OCT2, then you will end up really underestimating DDIs. That's what has been shown with Ranitidine. I think, yeah, it was the work of Ranitidine. So basically, you have really to take into account that. Hope I was clear enough.
Thanks, Kristen and Miley. One of our attendees asks, was the bidirectional OCT2 model included in either the metformin or ranitidine model? Previous papers have shown a difference in sensitivity of MATE inhibition in the metformin-cimetidine DDI depending on whether OCT was assumed as an uptake or a bidirectional transporter. And it would be interesting to know if a similar finding would be found for the renal impaired situation.
The OCT2 MATE cimetidine thing is an important point. I want to say that this work was done in version 15.1 of Simcyp, which did not include the electrogenic version of OCT2 transport. It's in, I think it came out in 16. I think it came out in 16. And that is what the BERT 2016 publication is about. And it does show that including the electrogenic transporter with OCT2 is more important. In my findings, I didn't see an impact of MATE inhibition on Metformin PK, which based on clinical data with cimetidine, this is not true. Cimetidine is a more potent inhibitor of MATE than of OCT2, and cimetidine does affect Metformin PK. So we would need to, so yes, we need to include the more accurate we have, the more accurate the model is at describing OCT2 transport, the better it will give us, the better predictions it will be able to give us, and the more accurate understanding we'll have of RI on metformin transport with OCT2. So there is a limitation here in what I've presented, and I would expect that if I were to repeat these experiments or these simulations, especially with MATE inhibition, that I would see an impact of MATE inhibition on metformin renal clearance if I was using the electrogenic version of the transporter in Simcyp. I'm not sure if that answered the question, but.
Kristen, someone asks, do you have any recommendation for a compound with about 5% renal excretion in humans from a mass balance study?
Recommendations on how that would be simulated in renal clearance and how renal impairment would impact that. It would really depend on the compound and how it's renally excreted. I mean, it could be, renal impairment could have some sort of impact depending on the properties of the compound. So, for instance, you know, if there's an inhibition on reabsorption of the compound, even if the contribution was only 5% in renal impairment, if there was an inhibition of this reabsorption, then, you know, we might see a significant increase in renal clearance. So it really depends on other factors than just the absolute contribution of the kidney. And there's a lot of information as well in the literature about impact of renal impairment on compounds that are not renally cleared. So compounds that are mainly metabolized. There's a lot of information showing that the impact of renal impairment on drug metabolizing enzymes has a profound impact on the PK of compounds. So if your compound is less than 30% renally excreted, it's less likely to be important, but it could still be very important depending, renal impairment could still be very important depending on the compound. And that's one of the interesting parts of the project that I didn't go through today, is that we are looking at compounds that have very low renal excretion and how they can be impacted.
Changes in transporter expression seem to be more straightforward to assess or to determine. How did you determine if the change in transporter expression also had there was a change in activity?
Yeah, so that's a good point. The change in activity, so I kind of went through it fast, but what I did was I looked for specific instances, usually in vitro, where a specific uremic toxin was shown to inhibit uptake of a prototypical substrate of a particular transporter. So for OCT2, Ranitidine inhibits uptake of its substrate, and then we have a Ki for that, or an IC50 for that. And then I used the concentration of, not Ranitidine, excuse me, but in the concentration of the uremic toxin in an RI population, and then I simply divided the concentration of the uremic toxin in the RI population by the affinity term, or potency term, and got an R value. So that R value is based on an in vitro affinity, an in vitro potency, and some sort of, you know, consensus concentration or maximum concentration in some cases of the uremic toxin in an RI population. And we know that the concentrations of uremic toxins can vary quite a lot between different individuals. And so, yeah, there's a lot less confidence in that parameter, in that R, but it's still an R value that came from something, as opposed to just completely arbitrary, where in AIM-1, you know, we just wanted to see no inhibition all the way up to a lot of inhibition. But in AIM-2, we wanted to see, what do we have evidence for? What makes some sense? Can we use what we have? Because that's what the real goal of the project is. We could look more closely. You know, we could do a toxin-drug interaction. We could do a lot of studies. But what we wanted to do was see, can we make better predictions with what we have readily available to us? So that was kind of the idea behind using estimates that we may not have, you know, a very high degree of confidence.
One of our attendees says, thank you for your wonderful presentation. And regarding pharmacokinetic simulation of metformin in moderate renal impairment, we see a slight gap between observed and predicted concentrations in the terminal phase. What do you think is the possible cause?
Yeah, so we thought about this a lot while we were, you know, going through this project, but in order to, you know, change that, we have to change the actual model. And we didn't want to modify the model, the base model at all. So it's really hard to say because there are so many different mechanistic components to this model that could be altered and you know, change something one way and it could affect other things. So it's hard to know without investigating it further. You know, something that I would definitely want to look at in the model is the absorption phase. So again, the model has a first order absorption, but you know, there are transporters involved there. And so, you know, we could have a more accurate representation of the absorption phase and the terminal phase. It could again be, you know, differential contributions of different transporters in the kidney, in the liver. It could be due to specific enzymes. You know, it could be saturation at higher concentrations, and you know, then in the terminal phase, the concentrations are different. So I can't say what it is, but again, that's something that if we were able to, we would just continue to improve these models, you know, because ideally we'd have, no models are correct, right? We just have the best that we have at the moment. So we want to keep improving them in order to get more accurate representation.
Someone asks, recent studies have explored whether the intact nephron hypothesis can sufficiently explain renal impairment drug interactions, mainly for OAT substrates. This is simulated by assuming proximal tubular cellularity is decreasing proportionally to GFR. Did you explore this for metformin as an OCT2 substrate?
No, I didn't, but what a great question. Yeah. So no, I mean, you know, the work here is based on the intact nephron hypothesis, but, you know, to break that down would really, really be interesting, you know, especially because we're looking at concentrations, you know, the proximal tubular concentrations. And so if, you know, the intact nephron hypothesis isn't holding, then, you know, there'd be other things, but quite honestly, I wouldn't know exactly how to try to get at that, but that's a great question.
Kristen, someone comments, in Figure 8, they noticed that the simulation still under-predict half-lives, and they wanted to know if you could comment on that.
I think this might be the similar question to the earlier question about, you know, missing observed Metformin PK in the terminal half-life. So it's not being captured well for RI in the model. It captures pretty well for healthy individuals, but it's still not ideal. So it's some process that's just not being accounted for or being maybe misrepresented a little bit in the model. But I don't have a concrete explanation for what exactly that is.
This looks to be the last question we can take in this time from the audience. I want to thank the audience for all the wonderful questions from Kristen. We have collected all of them, and I can give them to Kristen after the presentation, and perhaps she can answer some of them by email. Kristen, someone wants to know, with this improved model, would you be confident in using it for dose prediction for drug-drug interaction on OCT2 in renal impaired patients?
Well, that's the question, isn't it? That is the question. I would have to say at this point, no. I would not use my work that I've presented here to inform something like that. I think it needs a lot more confirmation, a lot more exploration. I kind of see this paper as kind of the first step. And it wasn't even to say, oh, 20% OCT2 expression, that's what we should be using. It could be it could be some other number, it could be 60%, it could be 80%, you know. But the idea was, can we improve it? Is drug transporter expression or, you know, inhibition, are these factors contributing to modified PK and RI? So I feel confident saying that, yes, these factors are important, and we can't just rely on changes in the physiological kidney, meaning like GFR and those types of things. We can't just rely on that, but we do need to look at transporters. We do need to look at enzymes. We do need to look at fraction and bound. We do need to look at inhibition. And then by adding more model substrates, I would like to see a lot more model substrates before we'd be able to confidently base our dosing adjustments on this sort of analysis. And also, I do just want to say too that it's not even that maybe we'll use this information to inform dosing adjustments, but we'll use this information to more accurately predict PK, be more confident in our predictions, and then maybe we have a more realistic understanding of what that observed difference might be in a PK study in RI patients. So it might be that we're just better informing the sample size in a clinical trial in a RI population. You know, the efficiency and cost in that way, maybe we're just affecting that, and we're not actually using this to inform the final dosing adjustments. So we've still got a while to go.